Okay, so I'm going to go live today, and I appreciate everyone that is just joining in. I'll repeat occasionally. Um, the gifts that you give go towards buying donated books for folks. So anybody that's able to give, just know that that's what it goes towards, and just be happy to start sending stuff here. In order to make this as efficient as possible, I'm going to look on my screen, kind of keep my focus on my screen so I can answer the question for the ones that have been submitted. And by doing so, my goal is to get through all of the questions, the more than 200 questions that are in my TikTok message box and also at drmikesays.com. By the way, if you want to send a message, that is the easiest way to send me a message is to go to drmikesays.com. And there's a form on there that says, have a clinical question. Now, this person here says, how close to your office do I need to be to make an appointment? I'm in Cumberland County, only 1 hour away from your new office. You have to live in holding North Carolina upside down. I'm still holding North Carolina upside down. Here we go. Let's try this. Anyway, you have to live in one of these 14 counties, okay? Alamance, Mecklenburg were the last two. They're bright yellow. They're the ones that have been added recently. So if you don't live in one of these 14 counties, I can't help you. And I will say that Cumberland County is not an hour away from Winston because I used to have to drive it all the time because my dad's buried in at Bragg. So, but that is the answer to that. So let's move on to the next one. My PCP is great, but pain management won't do anything and claim that I'm at the max. Wheelchair next. I don't want that. Nobody will listen. Previous dose I had a life. I want to go back. I want to go and not. Okay, my old dose that I was on was 20 ER 4 times. Okay, hold on a second. Was 20 ER and 420 IR. It's gonna be kind of hard, I gotta tell you, Joe, to get back to that dose. That especially if you're not on it currently. I think that it's just going to be difficult. If I were in your shoes, I would focus first on getting the 20 milligram the 20 milligram extended release, and take whatever I can get as far as IR. So go after the ER first, and then over time try and negotiate your immediate release dose increase. Don't try and buy the whole pie. The problem a lot of times is that you need to understand that this is a negotiation process and that and negotiations often happen over time. Um, and you're going to have to demonstrate, patience with the process. Do I think it's a load of crap how patient we have to be? Yes. However, even less reasonable is to think you're going to go to a brand new provider and say, by the way, can I have that's already 120 milligrams. Can I have 180 morphine equivalents per day? Because, back in the day that worked for me. It's not going to be that easy, even with me, to negotiate it like that. We have to talk about like, opioid naivety. And if you haven't been on that dose in a while, you've basically established a new level of naivety. And so, think strategically, think incrementally. And when you think incrementally, let me give you another piece of this. One of the things you don't want to do is you don't want to be in the habit of asking for that increase the next month and the next month. I generally recommend treatment change conversations happen no more often than every 90 days. By the way, if you're giving gifts, know that they're going to go to buy donated books. So please continue. Um, and I apologize, but that I'm not responding directly to your comments today. All this is going to go on YouTube. Later, you can leave me questions related to some of my answers on the YouTube channel. By the way, look up Dr. Mike Says on YouTube when you're going to find it there. Anyway, but you got to think strategically, and you got to think in terms of, anything more than what I have is still a win. So that's my answer on that one. Let's go to this one. I've been going to my pain clinic for years, never had a problem. Thank you for that. Been seeing the PA for about 2 years. Now that I've lost 110 pounds, she told me that she needed to cut back on my meds. That's ridiculous. All I take is oxycodone 10 and Soma, and I've tried to cut back. I've tried to cut back for 2 days, and I can't move. It is not realistic to lower someone's dose because they lost weight. The only thing that should be happening is that the pain plan should become more effective. Now, when the pain plan becomes more effective and they see that you're using less medicine, then you cut them back because you cut them back based on what you're seeing with consumption. You don't doctor numbers. I don't know how often I have to say this, but we got to get out of this habit of doctoring numbers, like numbers somehow are the patient. The patient is not the numbers. There's so much more than the numbers. So you losing 110 pounds should have nothing to do with your dose. The people that I have that are on the highest dose in my clinic all weigh less than 100 pounds. Okay? Weight has nothing to do with the pain plan. Of all the things, now, does being morbidly obese increase pain? Yes. Does losing the weight resolve the pain? Not necessarily. No, it does not. Okay? You have to judge the person in the skin that they're in and quit looking at the numbers. Let's move on. All right. This one says, out of nowhere, last month comes in and says, we're going to do a taper. I passed my drug screen, so there's zero reason for this. He put me on a. Okay. I've asked a couple before, but nowhere, out of nowhere, last month, my pain doctor comes in and says, we're going to do a taper. I passed my drug screen, so there's zero reasons for this. He put me on this medication and this dose and says I'm too young to be on it forever. You called it, sir. I'm screwed. Zach, I mean, I get it. What they're telling you is that you need a new provider. Whenever a person comes in and they tell you that they're going to arbitrarily taper you because you're too young or whatever the reason. When you don't have when they won't listen to your counter comments, I'm not saying that your counter comments get to win the argument, but if they won't even listen, if you're not even having a real discussion, then what they're telling you in all ways is that A, you need a provider, and B, they don't think you have the courage to go find one. This is why everybody needs to know if they are a kratom responder. I ever want you to have to manage your pain chronically on kratom, but if you know you're a responder, you are less beholden to them. You will not be as feel like you're over the barrel because there are just times when you deal with shit like this. This is gaslighting, y'all. I know that you know that. I know I'm preaching to the choir, but there's nothing about this that's anything but gaslighting. So if you're just coming in, remember all donations go to buy donated books. Just so you know that. But anyway, also so all funds from subscribers. So you can also subscribe. I have the lowest subscription rate too. But you could subscribe, and that's like $3 a month, and then you'd be given basically $1.50 toward donated books every month. So anyway, just understand that. All right, that's that one. Let's go to. We're going to change gears a little bit. That was everything I had pending on drmikesays.com. And remember, the easiest way to get a question to me, because I get so much information in uh hold on a second. So much information at TikTok that it's easier for me to filter here. Okay. Also, decent price here. When you buy from TikTok Shop, though, if you buy in the TikTok Shop, the book when you every four people who buy a book in the TikTok Shop allow me to give one away to the list. Currently sitting at 26 people who are waiting on donated books. If you need a donated book and not, you go here and you go and you choose need a donated book. It's in the drop down menu. Now understand this. I have 26 people that have been waiting a month. So I'm not telling you how fast I'm going to be able to get a book to you, but that is the way to go about getting it. Okay? Let's move to let's keep answering questions, and I'm going to move to the TikTok mailbox itself. Let's see here. TikTok. Good. All right. Hopefully this is the right account. Let's make sure. Come on, come on, come on. Let's see here. Messages. All righty. Messages, messages, messages. Okay. Now remember, we are absolutely going to post everything that we do on the live to YouTube later. So if you have questions about the answers that I'm giving, or if you want me to expound a little bit, the best way to do that is at YouTube once I post the live video. And once I post the live video, um, just know that you can ask me questions in the links. Now, I have a question. Here she goes. I don't even see your book on this page. Is this the real Dr. Mike? Yes, this is the real Dr. Mike. Dr. Mike says .fnp is my real account. All right, let's go to the next one. I'm sending my hubby your way. We are in Lexington. What is your practice name? I'm going to just answer this one. What happened there? I really hate the desktop version of this. I said, hang on just a second, y'all. I know it's dead air. I apologize. Uh, here we go. Here we go. Let me answer this question. Clinic full number is 336 300 8855, and my clinic is called Complete Primary Care and Pain. All right, so there we go. Now let's go back to the list of open. Whenever I actually go back and answer questions, I always go back to the oldest question that was sent me, which was in January 5th. I'm on January 5th right now. Lillington, no, I'm sorry, Lillington, you cannot drive this far. That's further away than Fayetteville. All right, let's see here. Can you help me find a location near me? That I'm not able to do. All right. Okay, let's see. I have a question. I don't know if you will see this, but I've been in so much pain for the past year and so tired, but the pain in my bone makes it impossible for me to sleep. I'm not a drinker, but I've been thinking lately, maybe I could take a few drinks throughout the day and one at night to see if it helps the pain go away. Alcohol is terrible for pain, and I can sleep. What are your thoughts on this? I hope you can see this. Have a good day. Jess, alcohol is terrible for pain. Most of the time, because it's a CNS depressant, it tends to make you, so alcohol tends to amplify whatever you're feeling. So if you are having happy feelings, then alcohol can a lot of times can lift that up even a little bit higher. But if you're in a bad place, alcohol takes you down that hole and will not let you go. Jess, I cannot discourage this thought enough. It would be better for you to take kratom, never having experienced it, and wonder if it will work, than it would be to try and treat your pain with alcohol. Um, it is problematic. It causes so many other health issues. Quite honestly, you know, if they were really being honest about, that the health hazards of things, they would be so much harder on alcohol than they would even being full agonist opioids. So no, my straight advice is please don't do that. January 6th. Do opioids cause hands to shake? No, withdrawing can cause hands to shake. I've been on 10 milligrams 2 times a day of uh, morphone ER and 10 milligrams 3 times a day of oxycodone. I don't think you're still on oxymorphone. I'm pretty sure they took that off the market. Anyway, so you might be on OxyContin, but and been on opioids since 2007. Been having hand shakiness for many years, and it's getting worse. Pain management doctor says I don't have Parkinson's, and he doesn't know why the shaking. PCP says it's not Parkinson's without testing, and it must be from the opioids. That's bullshit. The opioids are not causing your hand shaking, CJS Bear. The opioids are not causing your hand shaking. Okay? Now, you could have a benign tremor. There's a lot of reasons why you could have hand shaking. You could have nerve damage. Okay? There's just, and you're right. Says it's not Parkinson's without testing. That's some bullshit. If you've not been to neurology, that's where you need to go next. Okay? What I would say is I would be curious if, in addition to your pain medicine, remember all gifts, those that are in here, remember that all gifts go towards buying donated books. So please give it as you're able. Um, let's see here. Okay. But back to this. You should already have been at a neurologist. Oh, what I do as a band-aid until I got in with neurology. I might try some low dose gabapentin as an adjunct to your pain medicine at bedtime to find out if you get any improvement in the shakiness. Because remember, gabapentin was originally an anti-epileptic drug, and it's the only indication that it actually has. But there you go. I might try a neuropathic agent to see if the shakiness is less. But either way, it's bullshit to say it's not Parkinson's or that it is Parkinson's without testing. That's bullshit. All right. Now we're up to another question on January 6th. I have a question. I'm in California. I have interstitial cystitis and fibromyalgia. I'm so sorry. I have bladder irrigation monthly. I'm glad that you do that. I perform vaginal wand stretches, fantastic, and yoga stretching. You're telling me all about your and acupuncture. That's fantastic. I had referrals for pain management, but here pain management does not include pelvic pain. That's again some bullshit. That is some bull. How can you say you're in pain management, but you don't do pelvic floor pain? That's ridiculous. That's some of the most worst. That's some. Now you know what? I have learned that there are so many freaking causes of intractable, insane, suicidal level pain that I no longer feel like there's a worst. But anyway, um, I've asked my Euro doctor for payment for my flares, which I still get monthly, and he refers me to Azo and not to stress. That's a bunch of bullshit. What method would you suggest for me? I need some pain relief. Some days are very hard. The interstitial cystitis flare and fibro flare is debilitating. Any advice would be appreciated. Well, in the absence, first of all, don't give up looking for someone that's going to take you seriously. I think to a certain degree, you're being told right now that you need a new PCP. Now, I know you're in California. You can't just shit a provider that's going to listen to you. I understand that. But if I had a PCP telling me that I had a diagnosis or that I didn't have a diagnosis and hasn't already suggested a referral, they're telling you that you need a new uh, a provider. By the way, that is chapter. Hold on a second. That is chapter. That's after do not give them. This is the page beginning on 25. When you know you need a new PCP, okay? That is, let me just read this first paragraph for you. The single most important healthcare decision you can make is your choice of primary care provider or PCP. The PCP is the only person in your care system who lacks the ability to say, "This is not my problem." By definition, when they say, "This is not my problem," they are telling you that you need a new one. They are telling you to go somewhere else. And it sucks, and I'm sorry, and you can't just shit a new one. I get it, but your trajectory, your plan remains the same. I'm sorry for that. Let's take a look at the time. We still have time. Let's keep going. Tara, my palliative doctor suddenly left the practice, and there's no provider who will fill my prescription now. Uh, I've been on the same medicine for over 10 years. I have Ehlers-Danlos type 3, Marfan's, MCAS, gastroparesis, intestinal failure. I'm dependent on central lines and feeding tubes. Um, I'm pacemaker, that means stomach, GI dependent. No, excuse me. This is cardiac. I'm pacemaker dependent and on my fourth device after 13 heart surgeries. Superior vena cava syndrome, pulmonary embolisms, despite being on Lovanex and Eliquis. Can your clinic help me here in North Carolina? If you're in one of my, can I help you in North Carolina? Only if you are in these 14 counties. Only if you're in these 14 counties. And you can see we just added two. Okay? You have to be in the central part of North Carolina, one of the 16. I still keep saying 14. We cover 16 counties. And again, in those 16 counties, now that we cover Mecklenburg, that's nearly 40% of the lives in North Carolina because I got Greensboro in there, third largest city. Charlotte, largest, no, second largest city. Winston, fourth largest city. Raleigh is the only one bigger. So again, I can't stretch it any further than I already am. But if you're in one of those counties, yes, we can help you. All right, moving to This is Ames. My husband was hurt in, I don't know what OIF means, with a fall out of a PLS after being hit with an IED. Okay, these are all military terms. I'm sorry. Okay. Operation Iraqi Freedom is OIF, and he fell out of a personal landing uh, something. In other words, it was a vehicle after being hit with an IED. He came home and was working a pallet jack that hit black ice and overextended his SI joint. This was back in '05 to '06. 5 years ago, he was told it was in his head by WC, is a military facility. His care is mainly the VA, and he is a federal Leo. That's something with the Bureau of Prisons. He's had probably 25 injections, four nerve ablations, 24. Thank you for that. 24 nerves both times. He just had an MRI that has two tears in his left SI, and the right side is frayed and damaged from overcompensating. He's on three oxys and tizanidine, and he had to go through hell just to get that. Buprenorphine, no, excuse me. Oh, bupropion patches gave him first and second degree burns. Those were probably the generic. I'll tell you about that in a minute. Are there procedures that can be done? I know they're going to shove a spinal cord stimulator, and that's an absolute no to that. How can I help you? Deep tissue massages help him. That's fine, but they're costly. I understand, and I appreciate that. Thank you all for all the giving that you're doing. Okay, now let's start with the bupropion patches. The bupropion patches, if you're having a problem with the adhesive, it's because you're using the generic patches. The adhesive on the name brand Butrans patches are much better. They did not burn people. They will stay on for that whole 7 days. They are fantastic comparatively. One of the worst things they ever did is when they went generic, they got rid of the matrix delivery system, and that adhesive is a chemical hell. I really do understand that. Now, the three oxys and the tizanidine. What I would say, it still goes back to, here's how you negotiate the next point, Ames. Okay. You still kind of basically say, remember, the whole thing is don't tell them what you want. You say, my plan of care is not working. You specifically point out what functional things you're not able to do that you need to be able to do in order to have any sort of quality of life. Okay. And so the first thing, now the conversation actually starts out with, thank you for what you do. Thank you for what you do. It's not working, but thank you for that. At least I have something. Okay. And then you go into this, and then you say, what else can we do? And you have the courage to shut up. And I don't mean that you're shutting up because now it's time for them to talk. No, I just mean that sometimes we talk ourselves, we keep running our mouth and we give them the ammunition to say no. You have to keep this part of the story simple. This is what I need to do. This is what I'm able to do. What can we do different? Oh, also be prepared to talk about your all the okay, everything you're doing within yourself to manage your pain. I'm in the hot tub. I do these deep tissue massages when I can afford it. Is it possible that I can use a little bit of CBD? You look at the and side of it. But most importantly, when it comes time to what else can we do, have the strength to pause. Okay? I hope that helps. We're still on January 6th. I told y'all I get a lot of messages. All right. This is from Ray. I have a question, but I'm a diabetic. Okay, I have a question, but oh, no, direct messaging because I need more characters. I'm on Suboxone for 18 years. I now take 32 milligrams a day. There have been times in the past I had surgery, and in order to achieve effective pain control, I typically stop the Subutex several days before going. So traditional opioids will work. He did that, so I'm doing that. My question is there an opioid that can be prescribed after surgery that has the ability to muscle the buprenorphine off my receptors? Only methadone will has a stronger affinity than buprenorphine to the receptor. And as far as what dose, no, hydromorphone is not. No, you're still going to have to do a transition. Hydromorphone is not enough to force uh, buprenorphine off of the receptor. Only just about. If I'm wrong, y'all can let me know on YouTube. Okay, when I post this later. All right, we got time for one or two more. Y'all have been very kind, staying with me, listening. I appreciate that. I see all of you. I really do. I just really this this stack of greater than 200 messages actually causes my heart to ache just to see it. So I'm trying this to see if I can get all the way through it eventually. Let's see. Let's see what. Okay, this one I'm gonna have to translate just a little bit. Again, thank you. What a person with complex regional pain syndrome, rheumatoid arthritis, osteoporosis could use for pain. He's not taking opiates because my doctor is no longer working. He retired, and I don't find a pain management doctor in the state of Connecticut that will take care of me the same way he did. First of all, Margie, don't give up. Do not give up. Okay. You give up, the flockers win. The flockers don't get to win. So don't give up. I understand that that doesn't mean you can shit a provider, but don't give up. Now, I am curious. Do you know if you're a kratom responder? And I want you to consider looking at that. Okay. All right. But continue to look for a provider and honestly begin with your PCP. One of the things you didn't tell me is how much medicine you were on before. But based on how long you've been off medicine, I would be willing to, to have a conversation about start me somewhere. If you know what your previous dosing was and your PCP is willing to take it over, then you make that additional promise that it's kind of bullshit, but you make it anyway. If you get me on service, I won't ask for an increase. And why do you say something like that if you know that you might need an increase someday? Because you're trying to take care of the now. When you're a chronic pain patient, so many of us just have to deal with the now. I can't worry about the fact that next year, when I need more medicine, I'm probably going to be stuck with this sucky ass plan. Right now, I need to be on something besides what I'm on. I need some help. And I can't go on anymore with no help. So just remember that even when you make ludicrous promises like that, everybody in the room knows that you mean it a little. You understand what I'm saying? But um we also know that, it's not really a promise that you can make for the forever. But if it gets you through the today, the now, that's what we have to do. All right. Man, we're still on the sixth. Tony says, I've been on opioid management for rheumatoid arthritis for more than 25 years, low dose, 20 milligrams total per day. I've been on a patient at this pain management office for 6 years now. I also have a prescription from Ambien for psychiatrist, been taking it for 25 years. The pain doctor just told me I can't have both. I could go to sleep one day and not wake up. I live in California. What should I do? Move. No, I'm kidding. I'm kidding, but that is some bullshit. You are not going to all of a sudden not wake up one day for the pain man. But when you've been on one medicine for 25 years and that other medicine for 6 years, it is nearly impossible. Now, can chronic health conditions cause you to have an extra worry for accidental overdose because of what we're talking about here, because of it can lower your threshold for respiratory drive? Yes, all those things are true, but it's not this whole thing. The pain doctor just told me I can't have both. I could go to sleep and not wake up is bullshit. One of the chapters in the book, that covers this topic is called it's the spirit in which is prescribed. It's on page 54, and it's called When You Say No, Tell the Truth. If you're going to be a provider or a patient that is not in agreement and you're going to say no to it, it had better be a truthful reason why you're saying no. Don't just come up with this bullshit. You might not wake up one day. One day I was talking to a pharmacist, and a pharmacist tried to tell me, oh, no, I can't do that because I was trying to get one extra pill per day for like 7 days because the person had just had surgery. I can't do that. I have to worry about accidental overdose. Don't you think I have to worry about the same bullshit? I have to worry about it too. Good Lord. When you say no, tell the freaking truth. All right, Rebecca, this is our last one for this live. I just want to thank y'all for being attentive. I've had a lot of participation in here. I hope y'all are helping each other with the comments. My goal is just to keep doing this as often as I can until I get through all of your questions. And you notice, why do I go all the way back to the oldest question? Because I don't care who asks it. It is just important as everybody between the past and the now. And I do this so that you know that it meant something to me that you sent me this question. All right. Thank you so much for your work here. I have refractory RLS and I'm running out of prescription options. I have been through the dopamine agonist and the gabapentin pregabalin treatments. Neurologists in my state are not willing to prescribe opioids. What's the next option for standard RLS treatment protocol? I've tried medical marijuana, but it gave me intolerable anxiety. Do you think kratom would be worth a try in my situation? One of the things that I think that you need to know about Rebecca is okay? None of these are probably going to work as a single agent. So you're going to need to revisit the gabapentin pregabalin or the dopamine agonist when we do this, okay? Also, instead of medical marijuana, I would consider Delta 8 slash Delta 9 gummies and specifically talk to them about about calming. Let them know that sleep is one of your main requirements because you have intractable RLS. Now, opioids. I have to be honest with you. Of all the things that opioids work on, RLS is not one of the better ones. And I'm not saying it cannot be useful, but it's usually low dose. And again, it's in combination. It's a little bit of this, a little bit of that. It's like making a really good stew. Okay. You're just going to have a few sprinkles in there, a sprinkle of this, sprinkle of that. It's not usually going to be one medicine that makes you go, oh, not really. Not really. Not. I wish that that was the case. But RLS, you got to understand, RLS is it's mostly neurologic, and because it's an ongoing, intractable neurologic, that's what ends up causing the pain. So you still got to go after the root cause. And so it doesn't mean I would say absolutely not to opioids, but I would definitely be exhausting a lot of other things because I know the opioids aren't really going to do a lot for this particular situation. Do I think kratom is worth a try? Yes, but I think it's going to be less effective than things, and that's fine. It's appropriate. They just told me that I'm talking. Um, Decision is fair. The restrictions. They just told me that I'm talking about adult things. Yeah, I knew that already. Anyway, again, I think kratom could be useful, but probably not. If it was going to be useful, it would be the red strain. I hope that helps. All right, and that is it for today. Uh, let me make a note of this. I love y'all. I'm going to go ahead and post this to YouTube later. Y'all have been great. Still got 51 people in here. I cannot thank you enough for who you are and what you do, and I'll keep doing my thing too. Love y'all, no buts.